Tēnā koutou katoa, ko Hamish Wilson tōku wangua. Kia ora everyone, I'm a GP and Associate Professor of General Practice here in Dunedin, and welcome to this suite of short videos about persistent physical symptoms and in particular how to provide effective explanations. So the background is that for several decades now, many colleagues and I have been interested in those particular patients whose symptoms just don't fit well within the biomedical model. So these can be intermittent or occasional symptoms, as well as the more recognised patterns such as tension headache and stomach aches and irritable bowel syndrome and dizziness and so on. As you probably know, this is a very diverse group of symptoms that pretty much anyone can get, including us doctors and myself included. Our preferred collective name for them is persistent physical symptoms, or PPS, and this umbrella label can also include chronic pain syndromes and functional neurological disorders and so on. This is the term in fact endorsed by the Lancet in 2024, and it may eventually become more standard and replace all other terms in current use. We have done quite a bit of research over the last few years, and these videos are now part of our overall educational package that includes the Persistent Symptoms Handbook and various consultation skills workshops. And ideally, this set of resources will help you develop your own sort of workable framework for these sorts of patients, as most of us practicing doctors were simply not provided with such a framework in our own training. So our plan with these videos now is to help you develop some straightforward explanations that you can use for any patient who has persistent symptoms of this sort, whether this is a first presentation or a long-standing syndrome. Our target audience includes doctors in all specialties, postgraduate trainees such as GP registrars, medical students, and other interested health professionals. So regardless of your clinical focus or experience, there'll be lots of ideas and concepts here that we hope will be helpful, especially if you are getting ready to consult with one of these patients. And quite often, as you might have noticed in practice, these sorts of symptoms can get investigated ad infinitum, but for many patients, not much is found in any of the organ systems. So both the doctor and the patient can feel quite stuck. Conversely, we also address the long-standing fear of missing something major if the doctor forecloses too soon on this sort of diagnosis. Our intention with these resources is to address all those uncertainties more directly and to provide some better ways forward. Now please note, we are not throwing the baby out with the bathwater. Biomedicine has been, and of course still is, a very effective model. We use the same clinical processes as for any other presentation. It's just that up to the last decade or so, these diagnoses haven't really been considered as legitimate outcomes of working through the differential diagnosis. I guess you could call these illnesses a sort of a blind spot in an otherwise helpful model. And the handbook also includes current diagnostic criteria for most of the common syndromes. In terms of our kaupapa, watching these videos is essential preparation before attending any of the PPS workshops that we and other educators are now running. It will also be important to read various chapters of the handbook in advance. We have produced this locally over the last 5 years. It covers most of the necessary knowledge and physiology about these presentations, particularly how we can often make a positive diagnosis from the type of symptoms, the timeline, the overall pattern of the illness, positive clinical features, and the absence of red flags on history and exam. So making a positive diagnosis rather than a diagnosis of exclusion is one of the key developments in the modern approach to these sorts of problems. Changing tack slightly, we appreciate there may be several subsets of viewers watching these videos. Some of you might be watching compulsorily as part of a course. Others will be attending in preparation for a workshop you've signed up for. And as you probably noticed, this area of clinical medicine has long been quite challenging, even contentious for us doctors and for other health professionals. So there's some interesting historical reasons for that, many of which still persist, of course. So initially at least, some of you might be a bit sceptical about what we're offering. If that's the case, we simply ask that you remain open to these ideas, and perhaps you might come back to this material at another time. What we are hoping for, generally, I guess, is firstly that this educational package helps you to appreciate how these symptoms and problems are quite legitimate ones, that symptoms are related to normal physiological reactions. They arise from unconscious brain processes that are well below our usual level of voluntary control. And sometimes, unfortunately, they can persist and become well established. We're saying these patients are really no different to any other patients. They have symptoms that initially at least can be confusing and disabling for them. We need to use our usual whakawhanaungatanga and active engagement and respect and good clinical skills. I'll briefly touch on some neuroscience concepts at the end of this introduction, starting with why we can get things like goosebumps or shivers up the spine or even fainting at the sight of blood, all illustrations of neurophysiology at an unconscious level. Secondly, we hope these resources will give you sufficient confidence to include this sort of formulation in the differential diagnosis, and that you can make a positive diagnosis of PPS if that seems likely. Which also means that you would then become more judicious about requesting further investigations, and you would send the patient in the right direction for specific treatment. These clinical skills and behaviours would be great outcomes. And thirdly, we're also hoping that many of you will be keen to learn how to explain the pathways and the underlying mechanisms of these problems to patients, as this really helps to reduce their symptoms. This includes engaging with these patients over time to see how they're doing and offering more specific coaching on what they can actually do that will help. Now, the content of these demonstration videos is linked to the main chapters in the handbook. There is the autonomic or sympathetic nervous system explanation. There's one on pain neuroscience with Mr. John Dunbar, and one on functional neurological disorders, or FND. The final video is on persistent fatigue states, such as long COVID. This is a sort of a worked example of how we might apply these underlying concepts to a wide range of persistent symptoms. The videos also include comments from Professor Tony Dow in Wellington and Dr. Sarah Buchanan in Dunedin, as they have long-standing interests in these conditions. In the videos, we will also demonstrate how to change direction for a patient with problematic symptoms that don't fit the usual biomedical patterns. This is learning how to introduce these new concepts, moving away from further investigations for organ-based diagnosis and so on. This change in direction or tack takes skills and particular wording, and we're going to offer several ways of doing so. It does take courage to do this change in tack, so you need to know you're on solid ground before you try it. You can gain that ground by reading the handbook or watching any of the videos or podcasts or research articles that are now readily available. There's heaps of material out there that says pretty much the same as us about all these sorts of problems. In the videos, we will also show how you can offer physiological explanations, which varies a bit depending on the main symptom. Learning how to do these explanations in detail takes some practice, but the benefits can be huge for both the patient and for us professionally. Collectively, we and our clinical colleagues have seen lots of these patients recover from their symptoms, and some of them were really unwell and very disabled. So to enable that sort of improvement, you need to be confident about the framework you are offering. If the patient trusts you and believes in the message, then there's a better chance that things will improve for them. It will take time to gain confidence in these new skills, but if you give it a try and put in the mahi, you will have some successes and you will gain further skills and confidence. We also use lots of clinical stories about other anonymised patients to reinforce that recovery is often possible. Okay, so let's get back to goosebumps or jumping in fright at a loud noise or fainting at the sight of blood or persistent pain after the injury has healed or perhaps unexplained dizziness or, some of those weird or bizarre symptoms that just don't make sense anatomically, or even persisting fatigue after the virus has been eliminated, or even how patients who are given the sugar tablet in randomised controlled trials can both improve as well as get side effects like headache, fatigue, and those are known as placebo and nocebo responses. So what are the recent insights into how the brain and CNS work that have made such a difference in understanding what's going on in these sorts of situations? So without going into too much anatomical detail, The diagram on the screen is a schematic representation of the brain and spinal cord, which make up the central nervous system. You can see the dividing line between our conscious self and all the subconscious parts of the CNS that pretty much control everything that happens inside our bodies. The first main principle is that our conscious brain has quite limited control over most of our bodily functioning. Our heart, lungs and digestive systems, of course, are designed to function without us needing to think about them. Secondly, it's useful to think anthropomorphically, that the CNS sort of acts independently of us. We could imagine a little person in the control room who's in charge of what's going on in the body. Now, the problem with PPS is that sometimes the control room puts too much emphasis on previous data or information, or avoids other information, or somehow gets it wrong and makes skewed decisions, which can then lead to uncoordinated symptoms that don't make sense or which persist unnecessarily. To illustrate all this, the sympathetic nervous system, or SNS, acts automatically. So in response to cold or some emotions, for example, goosebumps are caused by involuntary muscle contraction around hair follicles to make them stand on end. And in evolutionary terms, this physiological process was supposed to warm us up or make us look bigger when under threat. They're a useful worked example of how the SNS acts below our conscious control in response to physical events or personal circumstances and feelings. The SNS is also supposed to quieten down after the threat of a particular danger is past, but in the modern world, persistent low-grade activation of the SNS contributes to many ongoing symptoms such as dizziness and fainting and muscle pain, fatigue, raised blood pressure, and so on. Furthermore, modern neuroscience tells us that our perceptions of the outside world are largely shaped by our prior memory, by what we expect to see and feel and hear and so on. So optical illusions are a good example. Our brains see the shading in squares A and B as being different, but in fact they are the same. This illusion is because it is quicker for the brain to use our memory of checkerboards and to guess what is happening in the shading behind the column. It's quicker for the brain to just fill in the gaps rather than looking more closely. It's a bit like those cooking demonstrations where the chef reaches down under the bench and pulls out the dish they had made earlier. This is a good example of current understandings in neurophysiology that the CNS sort of predicts and then creates the sensation that we actually see or feel. I appreciate this is quite a difficult concept to grasp initially, but it means that if the little person in the control room makes inaccurate predictions or doesn't coordinate our physiology so well, then you can get all sorts of problems, including abnormal movements, odd sensations, even dissociative attacks, as observed in FND. Now, these have been called brain processing errors, which is quite a good sort of phrase. This is a central premise in FND clinics when neurologists talk to patients about these symptoms. So these symptoms are going on well below our voluntary control or consciousness. Similarly, it's often stated now that pain is a sensation that is actually created by the CNS in order to protect us from further harm. Persistent pain of this sort is better regarded as a disorder of the pain system itself, rather than coming from ongoing tissue damage. So this is a central premise now in chronic pain clinics, and they spend a lot of time educating patients about this more nuanced understanding of the nature of pain. Just a couple of further points about neurophysiology. PPS are best considered as temporary physiological ones rather than as being structural or pathological or biomedical. These sorts of symptoms are inconsistent and they come and go, as we'll see in the demonstrations, quite different to, say, permanent loss of power and sensation after a stroke. Another key concept is neuroplasticity, which means it implies that the more a neurophysiological pathway is used, the more it is primed for use. This means that persistent pain patterns or IBS or similar can be triggered off quite easily by very small inputs. Neuroplasticity also means that pathways can decay if not used so much. Symptoms can be reduced if other pathways are used instead. So the key implication here is that an early diagnosis needs to be made when patients first present, so these skewed pathways don't become embedded and recovery will be easier. There's lots more detail in the handbook and how it all translates to clinical symptoms. So for patients, learning about these overall concepts can help them understand how and why they have various symptoms. You don't have to get into too much anatomical detail. It's more that they become open to these revised understandings of how the CNS actually works. This understanding is essential, as otherwise they will be much less likely to take up various activities or approaches that could reduce their symptoms. Well, I hope this is all starting to make some sense, as there's lots to consider. It has taken us quite some time ourselves to get our heads around these emerging concepts. However, our stance now is that all doctors can learn and apply these skills to their patients. You don't have to be a pain specialist or a neurologist to help those patients with the more persistent syndromes. We also believe that GPs and others in primary care are uniquely placed to make an early diagnosis and to help patients understand what is happening before those neurophysiological pathways start to become established. Okay, so that's it from me on this introduction. In conjunction with the handbook, we hope you find these videos interesting. Ideally, they'll be helpful preparation for the workshops and also useful for your own clinical practice.